Welcome to our presentation on advanced surface technologies for bone fusion. I'm Ken Burkus. I'm an orthopedic surgeon at the Houston Clinic in Columbus, Georgia. I've had the privilege to be involved in several FDA and non-FDA spine and bone grafting technology studies over the past several decades. And I'm very excited to discuss advanced surface technologies with you today. This presentation will cover three main areas: the current state-of-the-art of implants and ceramic bone graft substitutes, surface technologies that help promote bone fusion, and demonstrations of the usage and benefits of these advanced surface technologies. In spine fusion, we use an interbody implant in the disc space to fuse two vertebral bodies together. The implant provides fixation and height in the disc space and allows the bone graft to grow from one vertebral body through the implant and into the next vertebral body. We use bone graft to support the fusion process and to provide elements to support bone growth. These elements can include a scaffold, signals to nearby cells to grow bone, or living cells that can grow bone themselves. A variety of options are available for interbody implants and bone grafts, but opportunities exist to improve clinical outcomes for interbody and posterolateral spine fusions. Advanced surface technologies in both areas have demonstrated improved fusion outcomes, and we're going to discuss them in detail during this presentation. Let's begin by looking at the different types of bone grafts. Autograft is considered a gold standard and contains all the essential elements to support bone growth. It's harvested from the patient and often requires a second surgery site. This can lead to potential complications, including blood loss and infection. Allograft is recovered from human cadaveric tissue. With allograft, there is a perception of limited biological activity depending upon the type of tissue, and there can be donor variability among grafts. Recombinant proteins are manufactured using a cell-based technology that provides a supraphysiologic level of growth factors to signal bone formation. However, there are a variety of well-documented safety risks and adverse events with these concentrated levels of growth factors. Ceramics are chemically synthesized and have good manufacturing reproducibility, so they tend to be offered at a lower cost. They are typically used as a bone graft extender. Extenders are typically used with other types of bone graft, such as autograft, to expand the volume. It can be mixed with blood or bone marrow aspirate. Traditionally, the mechanism of action for ceramics is through osteoconduction alone. Ceramics serve as a passive scaffold on which new bone is formed. Many ceramics are porous, which facilitates osseointegration by allowing cells to have easier access into the graft. Over time, cell-mediated processes result in resorption of the ceramic by osteoclasts and the deposition of new bone in its place by osteoblasts. Ceramic bone graft substitutes can differ in three main areas: chemical composition, carriers, and architecture. Common components for the chemical composition include calcium phosphate, such as beta-tricalcium phosphate and hydroxyapatite. There are also newer ceramic biomaterials such as bioactive glass. The carrier component that holds the ceramic granules has an impact on the handling and formulation of these bone graft substitutes. Examples of carriers include collagen, alkaline oxide copolymer, and others, each with different attributes that can affect handling or fluid absorbency. There is also the architecture of the ceramic itself, which we can selectively engineer at different macro, micro, and nano levels. As we'll see in upcoming slides, the architecture of the ceramic can drive a biologic response. The architecture and microporosity varies widely among ceramic scaffolds, and the size of the surface microarchitecture can be an osteogenic factor. Traditional ceramic scaffolds are used as bone graft extenders. They require the addition of osteogenic cells or osteoinductive signals to form bone. However, with an advanced biomaterial scaffold, no osteogenic cells or signals are needed to form bone. It has the power to initiate bone formation on its own. The microarchitecture for this advanced biomaterial scaffold is optimized for new bone formation. Looking at this histology, a nano-structured ceramic with a micropore size of 0.2 to 0.5 microns results in virtually no bone formation in an intramuscular defect. A traditional ceramic with a micropore size of 0.3 to 4 microns results in no bone formation as well. By specifically dialing into a micropore size of 0.3 to 1.1 microns, the ceramic with the optimized microarchitecture can form bone on its own in an intramuscular defect. Here is a comparison of other commercially available ceramic scaffolds. At 12 weeks, in a canine intramuscular implantation, histology shows muscle tissue in purple, graft in black. One ceramic scaffold shows significant new bone formation. This is the same ceramic scaffold that possesses the highest area of percentage of bone in the same preclinical study. This ceramic, with the optimized microarchitecture, also consistently forms bone in an intramuscular defects across a variety of species, from canines to sheep to higher order primates. Since the technology is surface-driven and not pharmacologically driven, there are no dosing concerns. This advanced biomaterial scaffold we're discussing is called Attrax. It's comprised of traditional ceramic materials, beta-tricalcium phosphate and hydroxyapatite, combined at a ratio for balanced reabsorption. But it's the submicron scale surface topography that sets it apart from other ceramic bone graft substitutes. Unlike traditional ceramic scaffolds, Attrax initiates new bone formation on its own, without added cells or growth factors. Preclinical studies have also demonstrated faster bony healing compared to market-leading ceramics. Attrax is available in two formulations. Attrax Putty features an alkaline oxide copolymer carrier that is highly moldable and can form into a variety of shapes. It can be mixed with autograft. Attrax Scaffold features a collagen matrix that is highly absorbent for fluids, such as bone marrow aspirate. Attrax Scaffold is compression resistant, so it can maintain its form even after being hydrated with fluids. It can also be molded well. So far, we've discussed the performance of Attrax in an intramuscular environment. But let's now review how this translates into an established spinal fusion model. Looking at an established rabbit posterolateral fusion model, where bone is marked in gray, with Attrax Putty, there is a 23% bone formation at 12 weeks, compared to only 12% for active fuse and 8% for VITAS. This clearly demonstrates Attrax forming more bone throughout the fusion mass than traditional ceramic scaffolds. From the same study, the tensile failure load of the fused specimens was assessed at 12 weeks. Attrax Putty showed increased fusion mass strength compared to traditional ceramic scaffolds and autograft. On the right, you can see incorporation of the ceramic granules into a trabeculated transverse process fusion mass. Looking at Attrax performance in an ovine posterolateral fusion model, in the upper left, we can see the performance of Attrax compared to traditional ceramic and autograft over time. Attrax achieves complete fusion at 12 weeks when compared to autograft and a traditional ceramic. To the right, we can see a biomechanical analysis of lateral bending, with Attrax showing virtually no motion at 12 weeks, further indicating a strong fusion. On the bottom left, we can see the trabeculated fusion mass with Attrax, while there is unincorporated grafts with the traditional ceramic scaffold and an incomplete fusion with autograft. Here we can see Attrax scaffold being hydrated. Attrax scaffold has a collagen matrix that uniformly suspends the ceramic granules, and it is highly absorbent of physiologic fluids. Here is 15 cc's of Attrax, and I'm applying 30 cc's of cell concentrate, which has a much thicker consistency than bone marrow aspirate. You can see it absorbing almost all of the cell concentrate, nearly twice its volume, and yet it keeps its shape. From my experience, many other ceramic scaffolds tend to fall apart when they take on too much fluid. Here you see Attrax maintains its integrity. It can be easily cut and manipulated. It's hydrated fully with concentrated cells, plasma, all the way through the graft. This happened in about a minute, not delaying my surgical application at all for this product. Here, I'm performing a posterolateral fusion and placing Attrax on the decorticated transverse processes. Attrax fills the space, and it's compression resistant. Attrax handles extremely well, being able to absorb a significant amount of cell concentrate while still maintaining its shape and integrity. It does not break apart during implantation. It does a great job of staying in place as we apply the instrumentation. There is no migration of the ceramic granules. In summarizing Attrax, we've seen how it elicits robust intramuscular bone formation without the need to add cells or growth factors. In preclinical spinal fusion models, Attrax demonstrates increased bone formation, stronger fusion masses, and faster speed to fusion compared to non-optimized ceramic scaffolds. Attrax has comparable fusion rates to iliac crest autograft in preclinical spinal fusion models. Lastly, Attrax may serve as a more cost-efficient autologous bone graft substitute, while still providing powerful elements to support the bone fusion process. Now let's look at the implants. There are a variety of different technologies available, many with their own benefits and areas of improvement. You can evaluate implants in terms of their stiffness, structural integrity, and their imaging characteristics. Today, we can also evaluate implants for their osseointegration capabilities, the ability for bone to attach to the implant. Machined PEEK has been the market-leading material. However, it is lacking in its osseointegration capabilities. Newer technologies such as titanium-coated PEEK or roughened titanium have made progress with improved osseointegration, but it has come at a cost to other features, such as imaging or structural integrity. As we discussed, there are many benefits to smooth PEEK with its stiffness, structural integrity, and imaging. However, it is lacking in its osseointegration capability. We have tried to solve this issue with PEEK. Looking at the histology, you can see here the fibrous encapsulation around smooth PEEK compared to bone formation within the porous titanium or titanium-coated PEEK. What these studies don't tell us is if the material chemistry or the surface topography is what's driving these results. There are lessons to be learned from the titanium literature. On the left, you can see an early publication looking at threaded titanium implants. The body's response to these smooth titanium surfaces was to create fibrous tissue encapsulation instead of bony on-growth. On the right, we see data from an investigation of surface topography on the osteointegration of titanium implants. The graph of osteointegration strength shows smooth titanium bonds very weakly to bone, while porous titanium creates a strong bony interface. This clearly shows surface topography plays a role in the osteointegration capabilities of an implant. With these lessons in mind, NuVasive has re-engineered the surface architecture of PEEK implants and is the only company to offer Porous PEEK technology for spinal fusion procedures. Porous PEEK, under the brand Cohere, features an architecture designed to promote bone ingrowth while maintaining biomechanical and imaging properties of PEEK. The surface mimics bone with its highly porous interconnected architecture. The increased surface area and wicking capabilities of the porous surface improves blood-to-implant contact compared with traditional interbody implants. The mechanical properties of this material have been well established through multiple scientific publications. This peer-reviewed literature demonstrates that Porous PEEK retains the strength and durability of smooth PEEK. It maintains more porosity under physiologic loads and withstands impacted insertion testing, whereas titanium-coated implants risk delamination. Porous PEEK more effectively shares loads with interlocking bone compared to porous titanium implants. At the heart of this technology is the ability to solve the problem of PEEK integrating with bone. Recall that smooth PEEK, as demonstrated in many preclinical studies, tends to create a fibrous capsule surrounding the implant. You can see this in the histological image on the left. To the right, you can see bone interlocking with the porous PEEK, creating a bond between the implant and host bone in this preclinical study. Regarding imaging, the radiolucent polymer composition of Cohere cervical implants creates less imaging artifact and clearer radiographic visualization of the fusion site when compared to titanium. In an Ovine interbody fusion model, you can see a halo formation and artifact with the roughened titanium implant, while Cohere cervical clearly allows visualization between implant and host bone. These features all come together to deliver significant improvements in clinical outcomes with Cohere cervical compared to smooth PEEK and structural allograft in anterior cervical discectomy fusions. In this peer-reviewed study, significant improvements were observed as early as 6 weeks and were maintained out to 12 months. The early improvements in patients treated with Cohere cervical may reflect the stabilization created by this unique surface architecture. Here is a study I performed looking at early clinical and radiographic outcomes of anterior cervical discectomy and fusions using Cohere cervical implants. The 6-month X-ray and CT scans seen here show good incorporation of the implants. All patients radiographically were fused by 6 months, and all patients were clinically improved through 12 months. There was no evidence of implant migration, subsidence, or halo formation. My personal experience with Porous PEEK implants has been outstanding. I use Porous PEEK exclusively in my cervical, PLIF, and XLIF procedures. I have not experienced any implant failures, migration, or breakage. The porous surface of the implant does not break apart or fracture during vigorous impaction. The implants integrate seamlessly to the adjacent vertebral bodies. In summary, Porous PEEK is designed for osseointegration while retaining the mechanical and radiographic properties of smooth PEEK. Preclinical studies show Porous PEEK implants resulting in more robust lumbar interbody fusion in an ovine model compared to rough titanium implants. And in clinical studies, Porous PEEK implants promote early improvements in outcomes compared to smooth PEEK and structural allograft. In closing, these advanced surface technologies in ceramic bone graft substitutes and implants have demonstrated the ability to better initiate and support bone healing in spinal fusions, which can lead to improved outcomes for patients. The porous architecture of both Attrax and Porous PEEK set them apart from other technologies in their respective categories. From my personal experience, both Attrax, Scaffold, and Cohere have been tremendous tools for my practice in delivering consistent, quality, and cost-efficient care to my patients. I am extremely confident that technologies we discussed today will serve as a platform for future advances in spinal fusions and to continue to improve patient care. Thank you for your time.